Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 311 of our pharmacotherapy series, which majors in cardiac arrhythmias. The first question relates to patient SLD in part 310 of this pharmacotherapy series. On hospital day 2, SLD experiences a run of ventricular tachycardia lasting about 2 minutes. The cardiology consult service has recommended placement of an implantable cardioverter defibrillator, abbreviated as ICD. What is an implantable cardioverter defibrillator, and how does it work? Transvenous implantable cardioverter defibrillators are devices implanted under the skin with wires or patches that are advanced or attached so they are in direct contact with the ventricular myocardium. The implantable cardioverter defibrillator is composed of a pulse generator, sensing and pacing electrodes, and defibrillation coils. The pulse generator consists of a microprocessor, a memory component capable of storing ECG data, a high-voltage capacitor, and a battery. The microprocessor controls the analysis of cardiac rhythm and delivery of therapy. An electrode is usually placed at the endocardium of the right ventricular apex, but in some rare cases, it is surgically placed on the epicardium. Patients with dual-chamber implantable cardioverter defibrillators have a second electrode placed in the right atrial appendage. Biventricular implantable cardioverter defibrillators have an additional electrode placed surgically on the epicardium of the left ventricle, or more commonly, placed transcutaneously in a branch off of the coronary sinus. Defibrillation coils are positioned on the right ventricular electrode at the level of the right ventricle and the superior vena cava. In most implantable cardioverter defibrillator systems, biphasic defibrillation current flows from the distal defibrillation coil to the pulse generator and to the proximal defibrillation coil. Since 2012, numerous advancements in implantable cardioverter defibrillator technology have occurred. A. Development of longer-lasting batteries, that is up to 12 years for Boston Scientific models. B. Emergence of quadrupolar leads to optimized therapeutic efficacy through improved device programming. C. Development of subcutaneous implantable cardioverter defibrillators, abbreviated as SICDs, and D. Development of MRI-safe implantable cardioverter defibrillators, available in Europe. The SICD system, model SQRX1010, Cameron Health, Inc., San Clemente, California, consists of a subcutaneous pulse generator and a single subcutaneous electrode, comprised of sensing and defibrillating components. The pulse generator is usually placed in the subcutaneous pocket created over the fifth intercostal space between the mid and anterior axillary lines. Placement of the subcutaneous lead is parallel to the left side of the sternum, with its upper pole situated at the level of the sternal notch and the lower electrode positioned beneath the level of the xiphoid process. Some of the advantages of using the SICD system include elimination of potential adverse events associated with venous access, minimal physical stress on leads associated with cardiac motion, and relative ease of device extraction. However, unlike transvenous implantable cardioverter defibrillators, the currently marketed SICD has a larger pulse generator, along with having less data on long-term performance. Furthermore, the current SICD does not provide anti-tachycardia pacing for ventricular tachycardia. Multiple clinical trials have proved the superiority of implantable cardioverter defibrillator treatment over antiarrhythmic therapy for the secondary prevention of sudden cardiac death. On the basis of evidence from numerous clinical trials of primary and secondary prevention of sudden cardiac death, the American College of Cardiology, American Heart Association, Heart Rhythm Society 2012 guidelines for device-based therapy of cardiac rhythm abnormalities assigned a Class IA rating for implantable cardioverter defibrillator implantation in 7 groups of patients. Implantable cardioverter defibrillator therapy is indicated for a. Survivors of cardiac arrest caused by ventricular fibrillation or hemodynamically unstable sustained ventricular tachycardia, which is level of evidence a. B. Patients with left ventricular ejection fraction equal to or less than 35% caused by a prior myocardial infarction who are at least 40 days after the event and are in New York Heart Association functional class 2 or 3 level of evidence A. C. Patients with left ventricular ejection fraction equal to or less than 30% caused by prior myocardial infarction who are at least 40 days after the event and are in New York Heart Association functional class 1, which is level of evidence A. D. Patients experiencing spontaneous SUVT in conjunction with structural heart disease, regardless of hemodynamic stability, which is level of evidence B. E. Hemodynamically compromised patients with electrophysiology study-induced SUVT or ventricular fibrillation associated with syncope of undetermined origin. F. Patients with left ventricular ejection fraction less than or equal to 35% associated with non-ischemic dilated cardiomyopathy and are in New York Heart Association functional class 2 or 3, which is level of evidence B. And G. Patients with left ventricular ejection fraction less than or equal to 40% in conjunction with non-sustained ventricular tachycardia abbreviated as NSVT secondary to prior myocardial infarction, who experience SUVT or inducible ventricular fibrillation at electrophysiology study, which is level of evidence B. Although implantable cardioverter defibrillators have been shown to improve survival in select patient populations, the benefit may be offset by diminished quality of life associated with painful shocks, increased mortality compared with implantable cardioverter defibrillator patients who do not require shocks, and incomplete protection from the occurrence of sudden cardiac death. 5% of patients fail to respond. In recent years, investigators have examined various approaches to reducing the frequency of implantable cardioverter defibrillator shocks. Antiarrhythmic medications and prophylactic catheter ablation have been shown to reduce the incidence of implantable cardioverter defibrillator firing. The EHRA-HRS-APHRS Task Force Group assigned a Class 2A rating for the strategies of programming implantable cardioverter defibrillators to a delayed ventricular tachycardia detection interval and a high ventricular fibrillation detection rate in patients requiring primary prophylaxis. Defibrillation threshold is classified as the minimum amount of energy needed to result in successful defibrillation of the heart and restoration of normal sinus rhythm. It is important for clinicians to be aware that antiarrhythmic agents have been associated with increases amiodarone or reductions dofetilide in ventricular fibrillation thresholds. Clearly, SLD should have an implantable cardioverter defibrillator implanted. It is her best chance for prolonging long-term survival. Depending on the number of times the machine discharges per month and the patient's response, adjunctive antiarrhythmic drugs or prophylactic ablation may be needed, along with optimizing implantable cardioverter defibrillator programming. The next question reads, SLD's cardiologist would like to start amiodarone as adjunctive therapy because SLD has expressed concern about the number of implantable cardioverter defibrillator discharges that may occur after implantable cardioverter defibrillator placement. If SLD is to be treated with amiodarone, how should it be initiated and monitored? Amiodarone exhibits properties of classes 1, 2, 3, and 4 antiarrhythmic agents. Although it has class 2 effects on the heart, amiodarone is virtually devoid of antiadrenergic effects outside the heart and is not contraindicated in patients with asthma. The antiadrenergic effects arise from inhibition of adenylate cyclase, the enzyme that catalyzes production of the second messenger product cyclic adenosine monophosphate. Amiodarone can also cause a reduction in beta-1 receptor density. Because of the extremely long half-life of amiodarone, loading doses are used to accelerate the onset of drug effect. The OPTIC trial used a loading dose of oral amiodarone 400 mg, given twice daily for 2 weeks, followed by a daily dose of 400 mg for the next 4 weeks, and a daily maintenance dose of 200 mg thereafter. Although a concentration-effect relationship is hard to determine for amiodarone, levels greater than 2.5 mg per liter are associated with an increased incidence of adverse effects. Amiodarone has many serious adverse effects involving a variety of organ systems, the most serious and life-threatening of which is pulmonary toxicity. Amiodarone-induced pulmonary toxicity, abbreviated as AIPT, has been shown to account for 11% of the sum total of all reported adverse events associated with this agent. Amiodarone-induced pulmonary toxicity presents as an acute process or a chronic condition that develops several months after starting amiodarone therapy. The pathophysiologic mechanism for amiodarone-induced pulmonary toxicity has not been fully elucidated, but may involve a. heightened extracellular expression of beta-hexosaminidase. B. imbalance between T helper 1 and 2 cells, leading to a maladaptive immune response. C. increased tumor necrosis factor alpha activity, and D. angiotensin-mediated apoptotic effects of amiodarone on alveolar epithelial cells. It has been suggested that higher doses of amiodarone, older age, and pre-existing pulmonary disease may predispose patients to developing amiodarone-induced pulmonary toxicity. However, amiodarone-induced pulmonary toxicity has been shown to occur after patients received low doses of amiodarone, that is 200 mg per day. Manifestations of chronic amiodarone-induced pulmonary toxicity include cough, dyspnea, impaired diffusion capacity of carbon monoxide, infiltrates on chest radiograph, weight loss, and fever. In contrast, patients presenting with acute amiodarone-induced pulmonary toxicity experience rapid decline in respiratory function, potentially culminating in the development of acute respiratory distress syndrome, abbreviated as ARDS, with alveolar opacities. Given the prolonged half-life of amiodarone, symptom resolution will be a slow process for patients with amiodarone-induced pulmonary toxicity. Patients presenting with marked radiographic opacities and hypoxemia may need to receive prednisone 40 to 60 mg daily for several months. Mortality rates for patients with amiodarone-induced pulmonary toxicity have been shown to approach 10%, with higher mortality rates seen in patients requiring hospitalization 20% to 30%, or who develop ARDS 50%. A baseline chest radiograph and pulmonary function tests, diffusion capacity in particular, are recommended by the manufacturer. The chest radiograph should be repeated at 3 to 6 month intervals, and patients should be specifically questioned about pulmonary symptoms because early detection can decrease the extent of lung damage. Liver toxicity can range from an asymptomatic elevation of transaminases, that is 2 to 4 times normal, to fulminant hepatitis. The mean latent period between the start of amiodarone therapy and evidence of liver injury is 10 months. Onset can be as short as 3 to 4 days, but with rapid IV loading of amiodarone, ARIAs like fulminant hepatitis can occur as early as 1 day after starting therapy, most likely caused by the IV vehicle POLYSORBATE80. The precise mechanism of amiodarone-induced hepatotoxicity has not been fully elucidated. However, higher doses and prolonged drug use appear to place patients at higher risk of experiencing hepatotoxic effects of amiodarone. Thus, liver enzymes should be monitored at baseline 1, 3, 6 months, and semiannually afterward. The most common GI complaints are nausea, anorexia, and constipation, which occur in 25% of patients receiving amiodarone. Both hypothyroidism and hyperthyroidism have been reported, although hypothyroidism is more common. The thyroid complications are a consequence of amiodarone's large iodine content and its ability to block the peripheral conversion of thyroxine, also called T4, to triiodothyronine, also called T3. In addition, amiodarone and its metabolite, desethylamiodarone, appear to be directly cytotoxic to the thyroid gland. Recent reports have indicated that photosensitive eruptions occur in 7% of amiodarone recipients. Classical presentations of amiodarone photosensitivity involve a burning and tingling sensation in sun-exposed skin with accompanying erythema. Approximately 1% to 2% of patients receiving amiodarone for long-term use develop blue-gray pigmentation on sun-exposed skin. Resolution of amiodarone-associated photo-induced pigmentation may take up to 2 years, with gradual fading of skin discoloration. In recent years, amiodarone-associated optic neuropathy has been highlighted in multiple case reports. A review of amiodarone-associated optic neuropathy, from January 1993 till May 2011, revealed a total of 214 cases from the FDA's Adverse Event Reporting System, 59 published cases, and 23 cases from clinical trials. On average, patients received amiodarone for 9 months, ranging from 1 to 84 months, before experiencing vision loss. In 20% of cases, patients progressed to legal blindness in at least one eye. Other bothersome side effects are corneal deposits, usually asymptomatic, exacerbation of heart failure, and central nervous system effects that include ataxia, tremor, dizziness, and peripheral neuropathy. Other than eye examination and pulmonary function tests, which should be repeated when the patient is symptomatic, other tests should be repeated every 6 months. This applies to thyroid and liver function, or annually. This applies to chest X-rays, for routine monitoring. Amiodarone also blocks multiple cytochrome P450 enzyme systems and P-glycoprotein pumps, resulting in clinically significant drug interactions. The next question reads, PLG is a 69-year-old woman who is taking sotalol 80 mg twice daily for a previous episode of SU/VT. PLG was admitted to the hospital 3 days ago for altered mental status. She is also taking oral citalopram 40 mg every morning for major depressive disorder. At baseline, her QTc interval was 400 milliseconds, and her creatinine clearance was 50 milliliters per minute. Other laboratory values are as follows. Sodium of 139 millimoles per liter. Chloride of 108 millimoles per liter. Potassium of 4.0 millimoles per liter. Bicarbonate of 22 millimoles per liter. Blood urea nitrogen of 32 mg per deciliter. Serum creatinine of 1.5 mg per deciliter. Random glucose of 102 mg per deciliter. Calcium of 8.5 mg per deciliter. Albumin of 2.9 grams per deciliter. Phosphorus of 3.3 mg per deciliter. The next question reads, today, HO-ECG reveals a QTc interval of 502 milliseconds and torsade de Poor, with a ventricular rate of 110 beats per minute. What is QTc interval prolongation? Why does QTc interval prolongation indicate an increased risk of torsade de Poor? Could an antiarrhythmic agent such as sotalol cause this arrhythmia? How does creatinine clearance affect this? The QT interval denotes ventricular depolarization, the QRS complex in the cardiac cycle, and repolarization, that is, from the end of the QRS complex to the end of the T wave. Certain ion channels in phases 2 and 3 of the action potential are vital in determining the QT interval. An abnormal increase in ventricular repolarization increases the risk of torsade de Poor. Torsade de Poor is defined as a rapid polymorphic ventricular tachycardia preceded by QTc interval prolongation. Torsade de Poor can degenerate into ventricular fibrillation and as such can be life-threatening. Because there is tremendous variability in the QT interval resulting from changes in heart rate, the QT is frequently corrected for heart rate QTc interval. Several correction formulas for the QT interval exist and give similar results at most heart rates. The most common correction formula uses quart and RR intervals measured in seconds as follows: QTc is equal to QT divided by into brackets R minus half the value of R closed brackets. However, overcorrection of the QT interval may occur in persons with elevated heart rates, that is above 85 beats per minute. The Friederichia correction QTc is equal to QT divided by into brackets R minus a third of R closed brackets represents an alternative correction method for patients with heart rates exceeding 85 beats per minute. The ACC and AHA recently addressed the issue of the prevention of torsade de Poor in hospital settings. They stated that each 10 milliseconds increase in QTc confers an additional 5% to 7% torsade de Poor risk in patients with congenital long QT syndrome, abbreviated as LQTS. The International Conference on Harmonization stated that prolongation of QTc interval by more than 30 milliseconds and in excess of 60 milliseconds should be classified as a potential adverse effect and a definite adverse effect, respectively. Class 1A and Class 3 antiarrhythmic agents have been shown to induce torsade de Poor in numerous literature reports. Of note, Class 1A antiarrhythmic agents do not exhibit dose-dependent association with torsade de Poor, whereas the incidence of torsade de Poor does appear to be dose-related with Class 3 antiarrhythmic agents. QT prolongation associated with the use of Class 1A antiarrhythmic agents is likely the result of blockade of outward potassium channels, but it is offset by concomitant blockade of inward sodium channels at increased drug concentrations. Torsade de Poor induced by Class 3 antiarrhythmic agents arises from prolonged repolarization and cardiac refractoriness. All Class 3 antiarrhythmic agents have been implicated in cases of torsade de Poor. A recent review of the US FDA Adverse Event Reporting System, abbreviated as AERS, database showed the following number of torsade de Poor cases that occurred during a 2-year time period: dronedarone 37, amiodarone 29, dofetilide 12, and sotalol 4. Incidence rates could not be calculated because true denominators were not available and all events were self-reported. However, given the considerably larger prescriptive volume of amiodarone, this agent appears to have a relatively low propensity for inducing torsade de Poor. Class 1C antiarrhythmic agents do not exert significant effects on repolarization, and therefore have rarely been shown to induce torsid de Puer. To date, 8 cases of flecainide-induced torsid de Puer have been published, along with one report of propafenone-associated torsid de Puer. Sotalol is known to cause QTc interval prolongation in a dose-dependent manner. Total daily doses of 160, 320, 480, and more than 640 mg gave patients a steady-state QTc interval of 467, 473, 483, and 512 milliseconds, and the incidence of torsid de Puer was 0.5%, 1.6%, 4.4%, and 5.8%, respectively. It is likely that PLG's reduced renal function put her at high risk for sotalol accumulation and accentuated QTc interval prolongation. In patients with a creatinine clearance greater than 60 ml per minute, the sotalol dose of 80 mg twice daily is appropriate, but in patients like PLG with a creatinine clearance less than 40 to 60 ml per minute, the manufacturer recommended dose should be 80 mg daily or 40 mg twice daily owing to sotalol's predominant renal clearance. The next question reads, what transient conditions or other disorders can increase the risk of torsid de Puer in patients on Class 1A or 3 antiarrhythmic agents? Hyperkalemia, hypomagnesemia, hypercalcemia, rare cases of torsid de Puer, concurrent use of more than one QT prolonging drug, advanced age, female sex, heart disease, such as heart failure or myocardial infarction, treatment with diuretics, impaired hepatic drug metabolism, and bradycardia are important risk factors for torsid de Puer in hospitalized patients. Hyperkalemia may prolong QT interval by modifying the function of the inwardly rectifying potassium channel, resulting in heterogeneity and dispersion of repolarization. Prolonged ventricular cycle length can assume the form of complete AV block, sinus bradycardia, or a rhythm in which long cycles may progress to arrhythmogenic early after depolarizations abbreviated as EAD. Congenital LQTS occurs in 1 in 2,500 individuals, and is a channelopathy associated with mutations identified in genes encoding voltage-gated sodium and potassium channels. Since 1995, approximately 1,000 individual LQTS-causing mutations have been detected in 12 distinct LQTS susceptibility genes. The LQTS susceptibility genes KCNQ1 encoded IK's alpha subunit, KCNH2 encoded IKR alpha subunit, and SCN5A encoded NAV 1.5 alpha subunit account for nearly 75% of all congenital LQTS cases. Because PLG did not have a family history of hereditary LQTS but was being treated with sotalol, an agent known to be associated with torsid de Puer in renal dysfunction, it can be assumed that sotalol therapy was responsible for her arrhythmia. The next question reads, which non-antiarrhythmic agents cause torsid de Puer? What is the mechanism of torsid de Puer initiation in this situation? We will now discuss pro-arrhythmic effects of non-antiarrhythmic agents. Non-antiarrhythmic agents can also exhibit potassium channel inhibitory properties and can prolong the QTc interval. Most of these drugs, including arsenic trioxide, macrolide antibiotics, fluoroquinolones, azole antifungals, methadone, antidepressants, organophosphorus compounds, and antipsychotics, cause QTc interval prolongation by inhibiting the inwardly rectifying potassium ion channel, just like quinidine and sotalol. Moreover, toxic concentrations of non-antiarrhythmic drugs can induce torsade de poor as a result of large doses, impaired kidney or liver function, or other drug therapy that interferes with metabolism of non-antiarrhythmic drugs. On August 24, 2011, the US FDA sent out an alert to healthcare providers and patients on new dosing recommendations for citalopram due to concerns of QTc interval prolongation and torsade de poor when using this agent at higher doses. Key recommendations included: 1. Prescribing citalopram at a dose of equal to or less than 20 mg per day for patients older than 60 years of age, also, in patients below 60 years with hepatic impairment or taking cimetidine. And 2. Prescribing citalopram at a dose of equal to or less than 40 mg per day for younger patients. Hasnain and Associates recently conducted a comprehensive review of published literature on QTc interval prolongation and/or torsade de poor risk associated with antidepressants and second-generation antipsychotics, abbreviated as SGAPs. The authors identified the highest number, 16, of case reports implicating citalopram, relative to other antidepressants, including fluoxetine 9, escitalopram 6, venlafaxine 5, and sertraline 2. Case report material revealed quetiapine as the second-generation antipsychotic with the largest number of QTc interval prolongation and/or torsade de poor cases, 16, followed by ziprasidone 13, risperidone 13, amisulpride, olanzapine 6, and clozapine 5. The authors of the review noted that patients had at least one additional risk factor for QTc interval prolongation in 92% of the reports. In addition, they acknowledged that the information yielded by case reports did not allow for comparison between drugs and generalization to clinical practice. During the past 2 decades, multiple case reports of methadone-induced torsade de poor have been published. Guidelines recommend QT interval monitoring, but some experts have questioned the necessity of screening patients. Cao and colleagues reviewed the FDA Adverse Event Reporting System (FAERS) database for QTc interval prolongation or torsade de poor events linked with methadone compared to other agents, including antiarrhythmic drugs and other opioids. Between 2000 and 2011, the 3 most commonly implicated drugs included dofetilide 359 cases, methadone, that is 211 cases, and sotalol, that is 119 cases. The authors acknowledged limitations of their analysis, voluntary and selective reporting to FAERS, along with the inability to determine incidence rates, but suggested that a REMS specific to methadone may be warranted, in order to lower the risk of torsade de poor. The recent emergence of methadone-associated torsade de poor could be attributable to escalating doses used in recent years, given the preponderance of published cases of patients receiving very high doses of this agent. Currently, the utility of published cardiac risk data on anti-infective agents is limited, owing to underreporting, failure to completely eliminate contributory confounding variables, cardiac disease, electrolyte abnormalities, use of other QT prolonging drugs, and the retrospective nature of some post-marketing studies. However, the propensity of antimicrobial agents to induce QT prolongation appears to be especially marked with macrolide antibiotics. All of the commercially available antifungal agents have been shown to induce torsade de poor and QTc prolongation, with a larger number of cases attributed to fluconazole, followed by voriconazole. Among the marketed quinolones in the United States, ciprofloxacin appears to display the lowest potential for causing torsade de poor. Because PLG was taking citalopram in combination with sotalol, it is likely that QTc prolonging effects resulting from concomitant use contributed to the development of torsade de poor. The next question reads, how should torsade de poor be treated? What treatments should be considered for PLG? If the patient is significantly hemodynamically compromised, frequently associated with a ventricular rate greater than 150 beats per minute and unconsciousness, while in torsid de poor, electrical cardioversion is the therapy of choice and should be given immediately. Stepwise increasing shocks of 100 to 200, 300, and 360 joules monophasic energy can be tried if earlier shocks are unsuccessful. We will now discuss about magnesium. In a hemodynamically stable patient, magnesium is frequently considered the drug of choice to restore normal sinus rhythm. It benefits patients whether they have hypomagnesemia or normal serum magnesium levels. However, magnesium is not effective for patients with polymorphic ventricular tachycardia without torsid de poor and with normal QT intervals. Before administering magnesium, potassium levels should be supplemented to the high normal range of 4.5 to 5.0 millimoles per liter. A common magnesium regimen is 2 grams given for 60 seconds through the IV route, followed by an infusion of 2 to 4 milligrams per minute. The exact mechanism of action for magnesium in torsid de poor is not known, but it reduces the occurrence of triggered activity such as early after depolarizations. In addition, magnesium blocks L-type calcium channels in the membrane, and may stabilize the membrane gradient through activation of the sodium-potassium ATPase. We will now discuss other treatment options for torsid de poor. Numerous other strategies have been utilized for patients who fail to respond adequately to standard therapeutic approaches, including calcium channel blockers, alpha blockers, potassium channel openers, lidocaine, and mexiletine. However, the evidence supporting these alternative agents is not compelling enough to classify them as first-line options for abolishing torsid de poor. Cardio-acceleration with isoproterenol, 1 to 4 micrograms per minute, or cardiac pacing has also been shown to be beneficial. As described previously, the ability of sotalol, quinidine, and N-acetylprocainamide to prolong the action potential duration abbreviated as APD is diminished at faster heart rates, reverse use dependence. The more the inwardly rectifying potassium channels are activated, the less susceptible the channels are to inhibition by potassium channel blocking drugs. Transvenous pacing has been shown to be of some use in abolishing refractory torsid de poor. Before adjusting the ventricular rate to suppress ectopic ventricular beats, it is essential to ensure proper catheter placement and cardiac capture. In general, ventricular rates of 90 to 110 beats per minute can usually eliminate ventricular ectopy, but some patients may require rates as high as 140 beats per minute. Once control of torsid de poor has been attained, the pacing rate can be gradually decreased to the lowest paced rate that suppresses further ectopy and dysrhythmia. Because PLG is hemodynamically stable, a bolus injection of 2 grams of magnesium should be administered over 1 minute, followed by an infusion administered at a rate of 2 to 4 milligrams per minute. In addition, she should receive potassium supplementation infusion to achieve a potassium level of 4.5 to 5.0 millimoles per liter. If the arrhythmia recurs, cardiac pacing should be used. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 312.